Welcome to Conversations with the Modern Girl, the podcast hosted by myself, Shamika Patterson, the guru of mental health and well-being. Join me as we embark on a journey of exploration and discovery, as we deepen our thoughts, as we discuss topics that affect our community. I coin myself the queen of randomly thinking, and as I'm randomly thinking and having these discussions in these podcast episodes, I invite you to join me with these thought-provoking discussions on a wide range of subjects, from lifestyle trends to the culture of the Black church, and also discussing some obstacles that we face in middle-class America, also to the intersection of mental health and well-being. Be prepared to be inspired, challenged, and empowered as we engage in meaningful conversations that aim to spark positive change and personal growth. Get ready to expand your horizons and enhance your understanding of these important issues in Conversations with the Modern Girl. Much again for tuning in and listening to your girl with Conversations with the Modern Girl. Today I wanted to talk about health disparities among African Americans, and what made me want to kind of touch on this topic are it's different things. Most recently I read a article that stated that Black women are 25% more likely to have a C-section than white women. The research professor out of North Carolina State University was Andrea Corridor Waldron. She did this research study out of New Jersey where she was taking a vast number of, she went, I think it was 1 million births in 68 hospitals in New Jersey, and she did this took the data from those births to see how many minorities of African Americans were giving birth by C-sections versus white women, same hospitals, same circumstances, sometimes the same insurance carriers. She was trying to see what was going on there, because it's an alarming report stating that racial disparities in unnecessary C-sections has outstanding rates in New Jersey. And if it's in New Jersey, it's in other areas too. And the data that she collected was showing that Black women were 25% more likely to undergo a C-section than white women. And this research she pulled from this research and made the statement that she's suggesting that implicit racial bias among providers play a significant role in this rate. Because there's a financial incentive that's attached to that. In some hospitals, that incentive is attached to filling operating rooms. So not only is the hospital going to get a financial gain, also the provider will get a financial gain. So it's a win-win for them. And other factors that could also be responsible for that, say it's in relation to the disappropriate rate carriers over other states. So in other words, that the need for more research to be done in other states, we can do that, and we probably can find the same numbers as well. And so that sparked me to think about that a little bit more in depth, because I have met and come across a lot of women that have had C-sections. And when I was pregnant myself with my first child, I knew I did not want a C-section. I actually wanted to have a natural birth. I did not want to have an epidural. I wanted to, roll around the little yoga ball, get in the whirlpool, have a nurse. It was, midwife and all that. That's what the plan was. But of course, that went out the window when it was time to have the baby. I did have a birthing room, and I did not have a C-section, but it wasn't encouraged. It was not encouraged, what I wanted, the natural birth, without having the epidural. And so it was a negative experience for me, because the nurse seemed like she was very on edge. She was ready to go. That's how she came across. She adjusted the monitor on the machine. I don't know what it's called, but she adjusted it, and it seemed like my contractions started coming more and more and more. And it got so bad that I did have to go ahead and get an epidural, something I didn't want to do. And I felt very vulnerable and I wasn't able to, vocalize or fight back or say anything. I had to go along with the flow. So when I saw this article and I read this about these C-sections, I was like, well, I bet it was some women that probably wasn't even given a choice, about the C-section. I know people that they have been told me that I'm going to deliver on the 25th of March. I got to go check in at 6 a.m. And, it's not like natural birth when the baby comes when it comes and you may get an induction, but it's more so about this is your scheduled C-section time. And then another myth that goes along with that is if you have one C-section, you got to keep having C-sections every time you have a child. Now, if I'm wrong, somebody call me out, tell me that that's incorrect, but that's what a lot of women, Black women, are told, that if you have a C-section the first time, you have to keep getting these C-sections. I've learned that that's not true. Now, let's address these health disparities among African Americans in the U.S., okay? So, social determinants of healthcare are those are non-medical factors that affect our health, the outcomes that we have. It can include biology, individual behavior, socioeconomic status, physical and social environment, support, racism, discrimination, access to affordable healthcare services, legislative policies. These social determinants of health can happen in many levels for women and children, and they're intersecting across several domains of influence, including those things that I named: biological, behavioral, physical, social, cultural environments, and healthcare systems. These determinants of health are responsible for many of our health disparities, many of our health inequalities that we experience. It's not fair. It's unfair differences that we see in our health status between diverse groups of people within our country. I mean, that's what's going on. In a nutshell, that's what these social determinants are. Now, compared to our white counterparts, African Americans are usually at a higher risk for certain health disparities like heart disease, stroke, cancer, asthma, influenza, pneumonia, diabetes, HIV, AIDS. All this information is coming from the Office of Minority Health and also the Department of Health and Human Services. It is known that high blood pressure is common in 12% of Blacks versus whites. So the whites, their rating may be like 10% against our 12. And that age is like from 18 to 34. And it rises as the age goes up. So like it's common in like 33% versus 22% of those aged 35 to 49 years old. Diabetes is common in 10% of Blacks, aged 35 to 49 compared to whites, 6%, same age bracket. Stroke is present in 0.7% of Blacks, aged 18 to 34 compared to 0.4 of whites in the same age group. These are astounding numbers and differences. And I've been reading this book called Weathering, and I'll talk a little bit about that more later on. But that book talks about a lot of these health disparities, how it has affected us as African Americans, and how it has kind of been generational, not just based on our genetic makeup, but the experiences that we have experienced in life, the hardships, our circumstances, our socioeconomic status, our environment, not just for those that have a low socioeconomic status, but also middle class Black America, as well as upper class Black America. It affects us in different ways. That book is very, very good. And I'll talk about that a little bit more in a minute. But I recall having a health fair back in like 2007 to increase awareness of the racial and ethnic disparities that in healthcare that was affecting my community where I lived. And so I wanted to strengthen the patient and provider relationship. So I brought in a local minority primary care provider. I also brought in a specialist doctor that was a hematologist, oncologist. I brought her in. I brought in a local pharmacist, and they were all minorities. I brought them in, and I brought them into the community. I hosted it at my then church, and we had a forum where we talked about these health disparities. We talked about cardiovascular disease. We talked about diabetes. We talked about kidney disease. We talked about strokes. We talked about high blood pressure. We talked about those things. And the goal was to educate them and to help them bridge the gap between healthcare and the providers, but bridge the gap between access to healthcare, and to get familiar with providers in the community so it can kind of decrease the anxiety some people may have had in relation to getting healthcare services. Also educating them on what was going on with their bodies and ways that they could manage and control these diseases that a lot of them already had. And so having the local hospital involved, I had them there too. People were able to know their numbers, their labs. They would get the fingerprints so they can know what their labs were. And other healthcare agencies were involved as well, just community resources, so they could understand the resources and accessibility to those resources in that community. And the reason, my why, was because we as African Americans, blacks, whichever one suits you that you feel comfortable saying, are more likely to be diagnosed with one of the health disparities and die at earlier ages for all causes, as I mentioned earlier. It can be our socioeconomic status, it can be behavior, it can be biological, it can be physical, it can be social cultural environment. It's a lot. Those things, and that will inhibit us from being able to manage our diseases, thrive, and have a longer life because of those deterrents, those social determinants. So I've been in that game for a long time, that, reaching back to the community, educating the community, pushing healthcare, pushing wellness, pushing empowerment. I mean, that was in '07, and I don't even know. I think I have a picture from that health fair. Maybe I'll post it on my YouTube or something. But just trying to be a beacon of hope, a beacon of light, a beacon of reason in my community. And I said it before, if you want to do something, you got to get out there and do it. You just can't sit back and complain. You got to put in the work. During that time, I also tried to advocate for a Boys and Girls Club in that area, because my concern was also for the children to have somewhere to go and activities to have in the summertime, and to have great mentorship and try to do things like that. Again, just trying to help the community. But I digress. Let me come back. The original article that talked about that racial health disparity that comes with childbirth talks and speaks to how Black women are three times more likely to die from pregnancy related causes than white women. And a lot of those factors come back to those disparities, quality of care, underlying chronic conditions that I named, structural racism, implicit biases, the infant mortality rate continues to increase. It is an epidemic, y'all. It really is. The infant mortality rate among Black women is 10.5. This was pulled from 2021. It's 10.5, followed by Native American babies, Native Hawaiian and other Pacific Islander babies, also Alaskan Native. Their rates are more like 7.76 and 7.46 respectively. And Hispanics is more of a 4.79. Whites 4.36, and Asian 3.69. Let me say that again. Black women had the highest mortality rate of 10.55. It is an epidemic how we are losing babies at childbirth. Not only are we losing babies at childbirth, but we are losing our Black women giving childbirth. A lot of Black women in the United States disappropriately experience various adverse pregnancy outcomes, from the deaths at childbirth, from low baby rates. We have babies that are born, underweight. And these things are legacies of institutionalized racism and biases in medicine. It's a compound problem that's been around for years. Hence, the reason why a lot of minorities do not seek healthcare services until it is extremely too late. The bottom line is there are significant concerns when it comes to Black women and reproductive health. Not to exclude all the other minorities that face the same concerns and access to healthcare, but for this particular subject matter, with us leading with talking about the C-sections, the unnecessary C-section, we kind of, want to segue into that focus point, of Black women experiencing or having significant concerns when it comes to reproductive health care. Factors, as I said before, that play into that: racial trauma, discrimination, marginalization, systematic barriers such as systematic racism, implicit biases within the healthcare system, also with people being uninsured and not having access, to reproductive healthcare services. Those things can limit and contribute to pregnancy complications for Black women. As Black women, we go in and we see our providers, we talk about what we may be experiencing, and sometimes it's brushed off. A lot of times it's brushed off. A lot of times it is not really taken into consideration when we're speaking. Just like earlier when I talked about my birthing story of how I wanted things to play out. And then when I got to the facility, none of that I wanted was being done for me. It was just completely dismissed, like, whatever. And a lot of women experience, I bet you, if you ask your homegirl, ask your mama, ask, your friends, ask people, ask Black people that you're cool with. Now, don't go walking up and asking nobody this stuff now, but people that you're cool with, ask them about their experience with reproductive health. How has been your experience when you go and visit the OBGYN? What was your experience? Not just with childbirth, but just going in for your routine checkup, your pap smears, just to go in for something that you may have had a concern about. It could have been a prolapse bladder, anything. I want to know, what was that experience like? I guarantee you, if you were to ask 10 Black women this, each one of them will have a story for you. Each one of them will have something that happened to them during their experience and speaking with a provider. Not just in OBGYN, but in, primary care too. Black males can have the same type conversation. A lot of them don't even go see the doctor. A lot of them don't. But as a female, we are prone to go and seek health care a lot more than our male brothers. And in going and seeking help and trying to explain what you're feeling, there are a lot of times that we feel that we are dismissed. There is some underlying implicit biases there. Things that people don't even want to realize. We all have biases. Everybody don't want to recognize that, but guess what? You do. We all have some. Knowing is half the battle. And when you're in healthcare, you have taken an oath to provide care. It's not about race. It's not about socioeconomic status. It's not supposed to be about those things. But when it comes to minorities in healthcare, there is a racial health disparity that comes with many things, particularly with childbirth. That article is not in vain. That article is pointing to the point that 25% more African Americans are being scheduled for unnecessary C-sections for financial gain. We should be upset about this. Something should be said and done about this. It's not fair. There's a history of racism in healthcare. And that has been a growing thing since the Tuskegee experiment. And the Tuskegee experiment is only one issue that was brought to the forefront of what happened to our brothers and sisters when they were manipulated and tricked to be an experiment that they did not even volunteer for. When there was adequate medication and treatment for them available, but they were not given that. They were denied that. Just to see how far a syphilis experience can go and how bad it could be so they could put it in textbooks to teach others. Come on, I mean, what is her name? Henrietta Lacks. Her cells were taken from her. Those cells, those gems have been the blueprint to scientific research for so many diseases. They use that now in cancer research. They use that for so many things that they'll never tell you and disclose that about. But she is the foundation of science. Her cells were the foundation of science. And she was going and seeking help at John Hopkins. I hope it's John Hopkins, because if I remember correctly, it was John Hopkins. And they were experimenting on her. So you hear these types of stories that did make it to the forefront, that could be discussed openly, that we know about. But what about the ones that never gets a voice? What about the women that experience things that they have not been able to tell people about? What about the experience that they was doing with women in OBGYN care by letting them bleed out, cutting on them with no anesthesia, doing things that, cause harm to them? It caused significant harm to them. So you ask yourself, why don't people want to, get health care? It's simple. Look at the history. And because of that, it has affected people in their trust in healthcare. It has affected minorities, and particularly blacks, in their willingness to seek healthcare or to be trustworthy of people that are supposed to be providing them healthcare. We have to understand and know and accept that the history of racism within healthcare must be understood. You got to understand that in order to dismantle institutionalized racism in healthcare systems. Can I get an amen? It's got to be acceptable. You got to say it. You got to say it, and we can back it up with stories. We can back it up with data. We can back it up with whatever you need. But the reality is, you got to understand that in order to dismantle this institutionalized racism in healthcare systems. We got to have that. Not only do we have to have that, we have to understand and know that to create policies that protect Black women, that protect us when we are seeking healthcare. We have to have social and systematic changes to reduce Black mortality rates, maternal mortality and morbidity. We have to have that. So when I saw that article, it led to my thoughts in all of this. It led to this, and I was like, you know what? I'm gonna get on my podcast and I'm gonna talk about it and give a voice to this, because this is something that we address. And it's not just about people who may have Medicaid or Obamacare, Blue Cross Blue Shield, United Healthcare. It doesn't matter what your insurance is. If you Black, you show up 9 times out of 10, it's not going to be a great experience. Let's be all the way 100. It's not. A lot of us go into healthcare facilities with a little bit of anxiousness and anxiety when we meet our providers. A lot of us would rather have a minority provider. And sometimes, sadly, sometimes that ain't a good thing either. Now, I'm not knocking my brothers and my sisters that are physicians that are doing what's right. But for those that are just as dismissive, for those that treat us like cattle, for those who are insensitive, for those that do not want to hear our voices and do not cater to our needs, shame on you. And I am talking to you. A lot of times we don't want to deal with you either. Again, think back on your experience, your own experience, when you try to gain access to reproductive health care services. I bet a RC Cola and a moon pie that you have a story to tell. A story to tell where you felt prejudged, dismissed, inadequate. I bet you have a story like that. I got a lot of this information from the Office of Minority Health Services and also African American Health, the Centers of Disease Control and Prevention, the Center of Disease and Control and Prevention, African American Health Disparities with Cigna, African American and Kidney Disease. I pulled those references, these things that I talked about, in the data from that. I pulled it from those sources. I want to make sure I put that out there because I did use those sources in order to have this conversation today. Mitigating the root determinants of health to reduce health inequalities is vital because health is a fundamental human right, and the inability to prevent inequalities results in health disparities. We have to have a conversation about this. If you're a part of an organization, if you're a part of a group, if you're just among your homegirls, if you are part of a church, part of, anywhere where you can vocalize and start these conversations about health disparities among African Americans, do so. Be a voice, read about it, research about it, find out information about it, and have open discussion about it. We need to be our own advocates. We must bring that to the forefront. Nobody else is going to do it for us. If you think somebody else is going to discuss these things and advocate for you in a manner that only you, because you personally feel that, can do so, you're fooling yourself. You have to be that voice. You have to be that person that openly talks about it. I'd love to hear your thoughts about it. I want to talk about that book, Weathering. Because I feel like that is something that we all should read. We all should read this book. It is excellent. I know I will butcher her name, but it's Dr. Geronimous. Her name is Dr. Geronimous. I'm going to spell it for you. Geronimous. And the name of the book is Weathering. It's the extraordinary stress of ordinary life in an unjust society. This book, she did invasive research for years in order to provide public health statistics and data to show how systematic injustices take physical toll on Black and brown working class and poor communities. And she talked about systematic cultural oppression and economic exploitation. So marginalized Americans are disproportionately more likely to suffer from chronic diseases and die at much younger rates, as we talked about a minute ago, than their middle class and upper class white counterparts. Her focus was on that. She talked about Black mothers dying during childbirth at rates 3 times higher than white mothers. We just talked about that. White kids in high poverty Appalachian regions have a healthier life expectancy of 50 years old or more, while the vast majority of U.S. youth can't get that far. They can't fathom being over that age because of decades of health disparities and things that may cause them to get sick and die early, as we talked about. It is an excellent book. I really would love to reach out to her and see can I get her on the podcast to have a great open dialogue about this. I think it would be wonderful to have her on to talk about it, because in speaking about this article that I saw and then bringing it to you guys and talking about it on here, those are 2-3 step process. But I feel like getting that book, reading that book, understanding it, the effects of systematic oppression, including racism and classism, on our bodies, on our African American bodies, is something worth doing research and understanding and reading and having a conversation about. You can get her book, and I don't get any kind of kickback from this, but you can get her book on Amazon. I think it's like $11 or something, no more than $12 or something. You can get the book. You can download the book if you have Audible and just take a listen to it. Just listen to it. Tell me your thoughts. When you come, if you've read the book and you're out there and you're listening to this podcast, give me some comments. Let me know what your thoughts are about it. Let me know what your thoughts are about this podcast today, as we talked about those things that affect us in healthcare, as our whole focus has been on health disparities among African Americans. And I did focus more so on African American women in this one because the original topic was about Black women being 25% more likely to have a C-section than white women in that whole research they did in North Carolina State out of New Jersey. So I did kind of go with it from there in this segment, but we can't leave out our brothers either. Our brothers are suffered at the same rates. Many of them, like I said before, don't even go to a provider to see a doctor. because of those fears that they've had of past experiences and things that they have learned about, So I challenge you, I like a challenge. I challenge you to be more vocal in speaking about these health disparities among African Americans. I challenge you when you go to these political forums, when you have the opportunity presents itself for you to present or to discuss a topic, subject matter, choose this. Let's put a voice behind it. We can all make a difference. If you want to do something, you want to effect change, you got to get up, you got to get out, you got to do something, you got to get your voice heard. You got to advocate, you got to talk about it. You got to have tough decisions. We got to have tough discussions. Tough discussions, a tough decision to not be silent, but to get up and to speak up, not only for yourself, but for your people. I hope you have enjoyed this podcast on today as much as I have been so happy to deliver it to you. Again, like and subscribe. Leave comments. If you have some topics that you want me to talk about, put it in the chat, put it in the in my inbox, shoot me an email, whatever. I look forward to chatting with you again soon. Thanks. Thank you to all the listeners out there. I ask you to please go to my YouTube page and like and subscribe to Conversations with the Modern Girl. Also, take the time to follow me on my social handles. Instagram is Modern Girl Movement. Facebook, same Modern Girl Movement. Thank you.